Kidney cancer doesn't affect every community equally. For Native American populations, disparities are stark, shaped by history, geography, and systems that haven't always listened. In this episode, we hear from Dr. Ken Batai, Dr. Monica Yellowhair, and patient navigator Nancy Washburn. They help us understand why kidney cancer rates are higher in Native communities and what it takes to build trust, improve access, and offer care that respects culture and sovereignty. We'll talk about misdiagnosis, transportation barriers, and the lasting impact of uranium mining, and why community-led solutions matter most. A quick note. In this episode, we use the term Native American for clarity, while recognizing that many prefer Indigenous, American Indian, or specific tribal names. We use it with respect for the diversity and self-determinations of the communities we're talking about. This is Kidney Cancer Unfiltered, and you're listening to episode 3. Well, thank you all so much for joining me on this episode of Kidney Cancer Unfiltered. Before we get into it, I would love for each of you, in no particular order, so whoever goes first, to just introduce yourself and your background for our listeners.
Okay, I'll go first. I'm Ken Batai. I'm an assistant professor in Department of Cancer Prevention and Control at the Rosenberg Comprehensive Cancer Center. I have done many kidney cancer research focusing on disparities, and I've worked in Native American, American Indian kidney cancer issue, as well as Hispanic and other group as well. I aim is to try to help and understand the disparity, inequality, to improve the care for the underserved population.
Hello, I'm Monica Yellowhair. Kia ani nishin kitlichin ibashichin kizalanaidachite loka denanaidashinola. I'm a Navajo woman originally from Keyenta, Arizona, and currently serve as an assistant director for our Office of Community Outreach and Engagement at the University of Arizona Cancer Center.
Tego Scano, Dehayan Diax Yungyax. My name is Nancy Washburn. My Ongwahongwe name is Dehayan Diax, which means she crosses the field. I am Mohawk Turtle Clan of the Six Nations in Ontario, Canada. And I work as a patient care navigator for the Department of Indigenous Cancer Health at Roswell Park.
Well, thank you all again so much for joining me. I'm really glad that we're having this conversation. I'm Dr. Yellowhair, you may not remember, but I was one of the attendees at the Escape for Thrive conference in Arizona in January from Bagot. And you spoke about the American Indian population in Arizona and the rates of cancer, and kind of also not just the disparities, but the impact of like cancer care and what that looks like, and we'll get into that later. But I would love for you before to kind of expand on that presentation, which I just found so absolutely fascinating, because I had no idea, and I'm sure a lot of people do not know that kidney cancer, I think, was number 5 in terms of cancers where there is a strong disparity between the general population and American Indian population in Arizona. So I'd love for you to talk more about that research and what you found.
Yeah, so this was just based off of our health status profile for American Indians in Arizona. So our health department, the Arizona Health Department, does a great job in collecting as much information as they can. We can talk about gaps in data, and unfortunately, when we say American Indian, we're talking about all 22 federally recognized tribes with what limited information we can get. And so this is not tribal specific, but in Arizona, kidney cancer is number 5 in American Indian males compared to the rest of the male population in Arizona. Kidney cancer does not reach the top 10. But in American Indian females, it is number 10 as far as kidney cancer disparities. And when you look at the overall Arizona female population, again, kidney cancer is not in the top 10. So there are some concerns about why is that on the rise, not only specifically to Arizona, but I'm sure across the nation as well.
And thank you for that, and giving that more of that context. Speaking across the nation, I know Dr. Batai, you are doing a lot of work in this area. So what kind of research are you doing, and what are the tools and resources that you're using to do it?
So yeah, my research has been kind of divided into two aspects. One is more on the biological aspect and genomic aspect. So I do look at CT scans to measure adiposity and measure the fat around the kidneys. And that's one of the things we are doing, but we also look at the genomics, sequencings and metabolomics. For those, I mean, I don't use Native American or American Indian specimens. I'm not going to talk detail about it, but yeah, so I'm focusing more on the CT scans related things for the Native Americans and other groups. And other aspect of my research is the treatment disparity, looking at cancer registry data and any other data I can get hold of it, and trying to link to the neighborhood level, socioeconomic factors, and all those information, and trying to understand, first of all, characterize the disparities related to incidence and treatment, and trying to understand what factor, contributing factor for the disparities. So those are the kind of two areas of my research.
What are some of the key statistics and trends about cancer have you found in Native American population?
Well, one of the most important things is it's not just Arizona, it's all across the United States. Overall, kidney cancer is, looking at the literature, we saw that it's a really elevated increased risk of incidence, but also the mortality all across the United States, probably about twice as double the risk of the mortality from kidney cancer compared to non-Hispanic white. So that's the first, statistical finding that it's already reported. What we didn't know was that more of the treatment differences. And we went through different literature, different books and stuff. I never saw those statistics ever. And then we started looking at cancer registry data and other data to see different, trying to characterize difference in treatment. So Native Americans or American Indians are less likely to receive surgical treatment, even though they are qualified to receive surgical treatment. If they do, they tend to receive more of the aggressive, more invasive treatment. And there's a lot more data that we don't know about because we are using cancer registry data. So because for example, we don't have the data on BMI or comorbidities to really understand why there's a difference, but there is a huge difference in how patients are receiving care.
Now, Dr. Yellowhair, during your presentation, you touched on this topic about like treatment disparities and care disparities. Can you go more into why these gaps exist? What are some of the factors that influence these gaps in care?
Yeah, no, there are several different things that we have to take into consideration. Access to care. I know we might talk about it later, but there are also historical traumas and why people don't really go in for much medical needed services when they need to in a timely manner. There's barriers of transportation, getting time off of work. People who are not advocating for their own health, they may go in just maybe showing some of these pre-signs of different types of cancer, but they get misdiagnosed, and so they don't find out till later that they have a later stage diagnosis of cancer. And then also just not thinking about cancer being affecting their own personal health. And so again, always leads to our job is to also increase education and awareness about cancer so that way we get more people advocating for themselves and potentially get seen for get their cancer screenings done early.
Thank you. Now, Nancy, I wanted to talk with you, kind of just expanding on that and what you see in the work that you do with the Native American population and treating them for kidney cancer, or walking them through it, and their experience. What are some of the barriers that you see or that are brought to you, if you will?
I would add that it's all of what Dr. Yellowhair had said. Um, and more is some traditional people don't like to talk about the word cancer, as they may think or that it invites the disease into their life. So that could be a contributing factor as well, on top of all the other disparities like transportation, insurance coverage, time off of work, and advocacy. And that's where my role as a patient navigator comes in, to help patients understand what's being said and help patients use their voice when it comes to getting care, cancer care specifically, and addressing their providers, because some would be afraid to, or and that also stems back to that mistrust in the Western medicine.
I think that is definitely something we'll get into later. I do want to go back to the research, and this is a question for all of you, so whoever wants to jump in first. But in the research that you've done, whether it's at the patient level, the clinical level, what are some findings that are particularly surprising?
That's challenging to say, but based on what we know in the white population, that I can suspect some of the things we see is kind of understandable. So like the prevalence of the risk factor is very high in Native American population, like smoking, obesity, hypertension, diabetes. Those are risk factors, and just reading about all those risk factors in the white population and trying to translate into how we understand in Native population, we could suspect that we understand that this is a huge issue. But what we really don't surprise to me is two things. Number one, there's nothing done, nothing much done for kidney cancer, specifically for Native population, Native patients. So we really don't know anything much specific about Native population and how these things affect the cancer care, or kidney cancer care among Native patients. Another thing that I really didn't think about it, I knew it, but surprised to me was how the cultural aspect and mistrust and also historical context and cultural context really matter to the patients a lot more than public clinicians and researchers really realize. And getting into that is very challenging for me as an outsider, but it is kind of interesting to see how every time I talk to the patients or community members, I see it's also an important factor, but we don't really talk about in the other context when we talk about cancer research.
But I know one thing that doesn't get talked about a lot as well is potential environmental exposures. And so specifically in our region in the Southwest, there's a lot of uranium mining that has happened in the past. And so there has been research in the literature that shows that uranium also targets the kidneys. And so when you think about, and in particular, based off the data from the Navajo Epidemiology Department, the Navajo Nation kidney cancer rates are much more higher compared to non-Hispanic white people in the same area. So again, based on region and where people are living at, where they're getting their water sources, that can also lead to some of these things as far as getting higher risks of kidney cancer. And so that's also something to consider as well.
Now, could you talk more about those environmental risks?
I wouldn't say targeting, it's just where the uranium is located. So it
Yeah.
just so happens that the tribal lands that the Navajo Nation resides on, where we're from, has a largest amount of natural occurring uranium. And so when mining was done in the past, that led to a lot of mine sites not properly being remediated. And so it leads potential to contamination of water sources. There's also possibility of a lot of these areas that are not fully remediated, so you can be breathing in dust. There's more uranium mining that's starting to happen again here near the Grand Canyon. And so that will also be transported through the Navajo Nation and other areas so they can start processing the ore. And so that's also a cause for concern, is what these potential long-term chronic health effects are due to the uranium mining. And so um, that is something that a lot of the researchers, not only at this university, but other universities are also focusing on, to see and make those connections of what this chronic long-term exposure may be doing to organs. So, yes. And so there, like I mentioned, there has been research done in the past that shows that uranium does target the bones, lungs, and kidneys, just as part of how the body processes any type of metal and how it tries to expel the metal from their bodies.
Okay. And how does that play into the mistrust issue, right? Because again, there's that like long history. So how can you talk more about how these environmental factors and the mistrust, how they're connected and how that impacts cancer care?
Yeah, so especially when it comes to uranium, there has been documentation through the public health services and Indian Health Services doctors that the doctors knew the implications, the health implications of working in uranium mines, but they were specifically told to not tell the native people about those warnings and dangers with mining uranium. They were not given the proper PPE to mine a lot of this ore. And on top of that, there's also language barriers. And then a lot of the people who worked in the mine, they didn't have a Western education, so they didn't know the harmful effects of potentially working with this ore. So there was a lot of mistrust in that sense. And so I think it was finally into 1990, the United States passed the RECA Act, the Radiation Exposure Compensation Act, to help cover some of these medical costs that a lot of these uranium mine workers experience due to their time working in the mine. And so it was an apology in sort of a way, but also to try to help cover some of these costs. And so that historically also being acknowledged, that you have been lied to, that you were knowingly put in these harmful mining situations, and people were discouraged to prevent from telling you what may happen if you are working in these mines. And so again, leading into the distrust in that aspect, but also in the doctors that were there that were supposed to be helping them, and under the guise of, if you work in the mine, you will get free health care. But at the end of the day, they were monitoring what the uranium mining were doing to the miners.
Now, I know that from the research, with the research we have, that people in the Native population are twice as likely to die from kidney cancer and also to be diagnosed in later stages. In part, does that mistrust lead to both? Is there a connection between not having that trust in the medical system and both later stage diagnoses and mortality rates? Is that something, Dr. Batai, you've seen in your research?
Well, it is kind of difficult to quantify mistrust and how that much contribute to the advanced stage diagnosis. But yes, I would imagine that will be the one of the many cause. Or we talk about social determinants of health, social drivers of health, right? And being mistrust, its historical context, one of many that actually creates a condition in the native, community that has so many challenges to access in the kidney cancer care. So yeah, I think it's one of them.
Yes, so I would also say we're not only dealing with mistrust, but also I think it's also important to have our researchers actually go back to the communities that they're working with to build that sustainable trust. It's one thing for research to come into a community and try to recruit people for a research study, but it's another thing to drag them back out of the labs, to go back to the community and give that information back. Because there hasn't been a time where I've gone to a tribal IRB meeting and there's like, oh, well, we had a group already look at this, but it may be completely an unrelated study. But they say, well, what were the results of that? We haven't heard back from the researcher, and you're stuck there with trying to find to say, well, I wasn't part of that research project. I'm sorry. I wish they came back to disseminate this information back to you. So I think that's also something that's very important as far as trying to work back from that mistrust, but also making sure that the research benefits the community is also a big deal. I think that also must be important and kept in mind when addressing working with tribes. Not only that, bringing in the tribes to actually help you design the research project because they also have their own questions. And so I think working with tribes in that manner of respect and letting them be part of the scientific process is also important. So that way they can help the researchers guide what is more of a feasible question rather than just the researcher coming in on a one-sided token on this uh, partnership.
Now, Nancy, I would love for you, from the patient navigator perspective, to following up to Dr. Yellowhair's answer. How can patients get involved? What are, I guess, some practical steps for it to happen where they become partners in this research and they help build it in their community?
I will follow up to Dr. Yellowhair's notion of, bringing research back to the community, but also prior to doing any research, it's always good practice to ask for approval, to ask for permission. Don't just welcome yourself in and start taking numbers. Nations are on sovereign land, their data is sovereign, and a lot of them like to protect that. So even me as a patient navigator, I'm here on the Tuscarora Nation right now working, but it took 3 years to come in as a Roswell employee. I'm from the community, I'm from the area, I was born and raised traditionally. But because I work for an outside organization, I had to build that trust. I had to show up and, be consistent with my patients. And I think that would be one thing is like organizations being consistent with the patients. And at Roswell, when you're diagnosed and you come in as a new patient, you go through a process where you're offered like research studies and biobanking information, and patients have the right to say no. And they have, some do say yes. I found that more patients that I've worked with have opted to say no. But helping them understand, as a patient navigator, helping them understand what that information is that Roswell is looking for and telling them where that information is going and how it's going to better the future of cancer care and cancer research is part of my job. And if the patient still doesn't accept that, I accept their answer and, help them move on from that and, make sure I relay that information to the providers that they don't want their information or any of their tissue or specimens collected.
Now, just for our listeners who are not necessarily familiar with this topic, could you expand on what sovereign data means?
Sovereign data would be each nation is a sovereign nation that lives on the reservation. They own their own information. They own their own, land. They have no outside organizations, outside political sources telling them what to do, how to act, who to see. It is all tribally run, and it is up to them if they want to allow others in to collect any kind of data or if they want to share their data with outside organizations. So it's all tribally owned. There's no outside, law or anything that can force their hand into saying, give me this data or share this data.
I appreciate you giving that explanation, but I remember you talking about like a research study that you're doing or that is being done in Arizona, where this I don't want to say issue of sovereign data, but this having access to this data and working with the tribal councils, you've been navigating some challenges, if you will. Can you talk more about that research, kind of more of the challenges that you were facing and how you've been working through them, kind of, I mean, I guess, as a blueprint as for how we can better partner with these tribal nations to get this research, which we know will help with cancer care?
Yeah, so we have been in a 3.5, maybe 4 year long process of working with one of the tribes here locally in Arizona and Tucson. We're working with the Pasquayaki tribe to help them with their population health assessment. So we currently have a population health assessment that focuses on cancer-related information, and where people get information from about clinical trials. Have they ever been diagnosed with cancer? So we've done that throughout Southern Arizona.
Mhm.
And so we're working with the Pasquayaki tribe. Of course, we're letting them take the initiative on this. Again, building that partnership, making sure they get to have a say in what the survey looks like on their tribal lands. Because with the survey that we've done throughout Southern Arizona, we did not recruit on tribal lands out of respect for tribal sovereignty. So if we have any tribal data that was collected, it was someone who self-reported it, and they were not on tribal lands. And so this particular survey that we are working with the Pasquayaki tribe, they actually have their council members look at the survey. They get to strike out any questions that they want to be asked, but they also get to add their own questions that they want to know to help them fill in their gaps of information that they're needing. The information in our hopes is for them to help better their cancer prevention programs as well as other services needed for cancer care. And so the longest part of it is not only working with the tribe for the internal review board and IRB statuses, but also and working with our and on our university side for our IRB purposes, but also who owns the data, who has access to the data, all again based on principles of tribal sovereignty and respecting that. And tribal data sovereignty. And so with us, we are pretty much just working as a support team. And so they will have access to the data. I'm a co-PI on the project, and I won't even have access to the data, is how safeguarded we're keeping it. We're making sure the tribe has a full ownership of the data. We're here in a supportive capacity. We're going to be helping train their nurse navigators to actually conduct the survey. And our data team is going to be helping them build up the data repository for them and training their tribal members on how to access the data. We're just going to be solely helping them as far as giving any recommendations and what they can use for the data, how to analyze, interpret the data. We're taking the back seat. We're letting them have full control access to their data and what they do with it. And so it's a unique process. It's so, like I said, it's working with all of our lawyers on our end and their tribal lawyers to making sure that the tribe gets what they need. And again, just being the support team behind them to help them get this information that they need.
Thank you. And I'm going to have one more question about research, but I do want to shift also to the clinical experience as well to talk about these disparities. So, Dr. Batai, I know that the KCA and data health company Tempus are collaborating to learn more about kidney cancer in Native Americans. Can you talk more about that research?
One of the things was that we were getting funding from the local, the tribal communities to do this kind of work, trying to understand the kidney cancer burden in the American Indians. We are trying to do a couple of things. One is going through all the literature available to see what are the causes of the kidney cancer, the increased risk of incidence and mortality. We are going through the literatures and writing up the papers and also report to the community so they can actually look at what current science can tell us about kidney cancer in the Native Americans, what potentially we can do. So we're trying to figure out actually what actionable things that community can address to improve the care for community members and prevent the kidney cancer. So that's one thing we are doing. Another thing is looking more of the genomics aspect of the kidney cancer. So this company is actually the genetic testing or biomarker testing company. So they do have a kidney cancer patients sequence in the genomic data. So we are looking at some other racial minority group like Hispanic population, because they do have a Native American genetic contribution based on the historical process, colonial process happened in Latin America. We may hoping to leverage those genetic ancestry to figure out how those genetic components might be correlated with clinical characteristic or genomic characteristic that predict aggressiveness of kidney cancer.
Thank you. And I think that leads me somewhat into my next question about what can be done in the short term and the long term to address some of these statistics and how kidney cancer impacts the Native American population. So both research and clinically, and I think definitely want to get into the clinical aspect. What can be done?
Sure. I mean, there are a lot can be done because, like I said before, there's not much done on this topic and Native American. So that whatever we do is going to be new, and so there are a lot of things can be done. But going back to some of the things Monica and Nancy was telling us about community priority, what they want us to do, it's not specific to kidney cancer. And this is more of the general health and access issues. For example, we can look at, if we want to prioritize a patient community impact, maybe we have to look at obesity, comorbidity, like diabetes, hypertension, and chronic kidney disease. Those are the important things that affecting native populations, but also associated with incidence and mortality of kidney cancer. So we could address those issues as overall bigger issue. And also we can look at access to care issue, social determinants of health issue. All those are important, something actionable, not like looking at the genetics to try to do something about it, but we can actually look at the social determinants of health and figure out where to address it, improve the care. And overall, I think kidney cancer is not well understood in the community members. We need to increase awareness of kidney cancer. I did survey once, and we asked about kidney cancer. Most of patients and most of community members didn't know about kidney cancer. And if for the people who know kidney cancer, they give us a not right answer in terms like not relevant to kidney cancer. They tell us about kidney disease aspect, like talk about jaundice, or so the symptom is related to chronic kidney disease. Treatment is more for kidney disease, not kidney cancer. So there's a misunderstanding what kidney cancer is and what kidney disease is. So
Nancy, just kind of building off of his response, we've talked about the social determinants of health a couple of times throughout the conversation. So I would love for you to expand on what are some of those social determinants of health and how can we address them?
Increasing patient
some of the social determinants of health in the Native American populations are access to care,
awareness
and
of
whether that's access through transportation means or access through coverage means.
The patient navigate the one who's actually doing
tribes
all
that
those
qualify
things
for Indian Health Service, or you'll
level.
hear say
Also,
IHS.
if there are more
And there are certain
it's
guidelines that
usually helps.
those certain or
it's
those
shown to
IHS
help.
facilities follow.
That's
So if
something
you're
really can be done
enrolled
right
member
away,
of a certain
as long as
tribe,
there's
you
a
may fall
funding
into
for
a
the
certain category
service.
in their system for certain kinds of coverage. It can get very confusing very quickly, especially for a newly diagnosed cancer patient. So that's where a patient navigator may come in and help them understand those routes that they need to take to get their coverage. IHS in our area helps cover the transportation, but not all community members are aware of that. So that's where, again, my role would come in, say, hey, this is, provided through this service, through IHS. Let's see if you qualify. How do I do that? Well, these are the steps you have to take. And that's where we help explain everything and help community members understand there is a bit more access that they have. They just don't know about it. So like Dr. Batai said, creating that awareness, educating our community members on, their resources in the area, and helping them, advocate for themselves when it comes to getting seen and getting the care they need.
Now, I know that there's also this challenge between, traditional medicine, if you will, and modern medicine, and the modern, providers not necessarily being considerate or understanding a need to incorporate traditional medicine into care. Can you talk more about that kind of gap, if you will?
Yeah, so Roswell has actually been really good about educating on cultural competency and providing care. I can use myself as an example. I'm a cancer survivor. I was diagnosed with ductal carcinoma in situ in 2022, and thankfully I only had to go in and have surgery. But when I went in, I was wearing Indian or Native medicine, or I was wearing tobacco with me, and I was asked to take it off. And I said no. So being able to speak up for myself and say, this is why I'm wearing this, this is my protection, you know, really helped providers understand my point of view as a patient, when it came to how spiritual I am with my tobacco. So as a role, in my role as a patient navigator, if I have patients come in that are also wearing tobacco or using traditional medicine, I always encourage them to make sure that they speak up to the provider, to make sure there's no interactions, to make sure that they're getting the best possible care they can possibly get while using their traditional medicine. And if that traditional medicine is interfering, making sure that they get an explanation as to why they should stop the traditional medicine if it's needed, if it's interfering with their Western medicine.
Now, I hope you don't mind me asking, but can you explain the importance of wearing tobacco for myself and listeners as well, so we can understand that?
Well, I wear leather with tobacco, and it's for protection, like spiritual protection. And sometimes people will wear sage or cedar,
Hmm.
and it's to ward off, you know, negative energies. It's I was actually just reading it over this morning. It is depending on how you look at it as a traditional person, and I will you know say each tribe is different in how they use their medicines. So my tribe in particular, Mohawk, we use it as, you know, protection, and to ward off any kind of negative energy. So myself, I would look at cancer as being negative, and I would wear it as to protect and ward off any kind of cancer.
Thank you for explaining that. I appreciate it. Now, Dr. Yellowhair, I would love for you to kind of just build off of the social determinant of health and cultural competency, that conversation. And you could take it any which way, but just kind of what in your research have you seen with social determinants of health and how it impacts cancer rates, and kind of what we can do to close that gap?
Well, I think Dr. Batai and Nancy said it all. There's a lot of things when it comes to when you think about social determinants of health as a construct, but also from a Native person point of view of it, it all comes in together. So if one part of the construct is out of balance, it's going to affect everything else. And so until you address that is causing that imbalancement, it's going to have a ripple effect all across all the other social determinants of health. And so I think a lot of that also comes to also increasing education and awareness. I know at our cancer center, we try to get more culturally appropriate information out there to each of the groups that we service. Well, not only that, native, non-native, we want to make sure that we are getting the right information out and awareness, especially to the people who we serve. But also, again, thinking about how people think about their healing process. We too, as well, at the Cancer Center here at the U of A, we also have a Circle of Holistic Care program where we try to incorporate cultural and traditional healing aspects in one's patient care. So there's many different avenues of what that may take and what that may look like. And a lot of part when it comes down to just the survey that we've done with our cancer patients here, a lot of them want to focus on physical well-being as well as dietary needs. And so unfortunately, some of those things are hard to change as far as when it comes to rural areas. And so the people might not have the full access to grocery stores where they need to get fresh foods and vegetables to help improve their diets. I mean, um, again, I'll use the Navajo Nation as an example because I am a Navajo woman and we have a huge landmass and we only have just a little under 14 grocery stores that service that whole area. And so, um, Yeah, so there's some things that can be addressed, but there's also some things that takes a larger effort that are a little bit beyond out of our control. So
But I know we have a few minutes left, so I do want to ask, what are some additional next step research questions we can ask that can address a lot, or if not all, of the topics we've covered today?
That's a difficult question. I guess for me, it is what I wanted to do understand is more of the obesity and comorbidities. I think it's not specifically for American Indian Native Americans, but that helps a lot for many different patients, how obesity and comorbidity affect survival and quality of care, quality of life after the treatment, because those are the impacting a lot more Native American population. But but we don't really know how to incorporate some of the things, like especially the obesity. Data is telling us so many different things. So like biology says it's obesity at high adiposity is terrible for the survival and quality of care, but the data sometimes tell us it's an obese patient has better survival. Then how are we going to use that information to help the patient? It's very difficult. So we have to really understand those things. Again, access to care is always an issue, and we can do a lot to, for the researcher, we can do a lot still to how to improve the access to care, more in the implementation and dissemination research aspect. So we can do a lot more for that as well.
I know we touched a little bit on this, but what can medical providers do to help close these gaps and to help address these disparities?
Yeah, there's something they can do. I mean, first of all, medical provider, I hope they understand the Native American culture and history. That's the first thing. I think academic center, they are trained to respect Native American patients, but in their community clinics or other large healthcare system, that may not be true, and it's challenging. So they need to understand to be more respectful, diverse group of patients. I think that's important.
I will say my biggest advocacy thing is to support our patient navigators and our community health workers.
Yeah.
Nancy's doing the job, boots on the ground. She meets with everyone. They are very important. We have researched in our moonshot project that we show that the power of patient navigators is great, and we need more of them. Give them everything that they need to get their job done, and they are the glue.
Thank you, Dr. Yellowhair. It's nice to be acknowledged that way in my work, because sometimes you feel like you're at a standstill in the work that I do. Sometimes you hit a wall and you're like, how do I get this patient to the next step? How do I get this patient seen? And you go down, 15 different avenues, and you finally find that one that gets the patient through to get the care they need. And I say it's so many, like such a big number like that, because sometimes it is. Sometimes connecting the dots for a patient, which can be exhausting for me, let alone a patient that's been recently diagnosed. They might just say, you know what, that's too much, I'll forget it. But so being able to, create access for patients is really rewarding in the work that I do. And I can't say this enough, that patient navigation is definitely a tool that all tribal nations should have in their communities.
But thank you so much then for joining this conversation and telling us more about it and what we can do and what we need to understand about kidney cancer in the Native population and where we need to go with their research. Thanks for listening to Kidney Cancer Unfiltered. If you found this episode helpful, be sure to like, share, and subscribe wherever you listen to your favorite podcast. For more resources and episodes, visit kidneycancer.org or follow Kidney Cancer Association on social media. Until next time, take care, and remember, you're not alone.